Good morning, good afternoon, good evening. Thank you for joining Centogene's webinar on Duchenne muscular dystrophy and Becker muscular dystrophy today. My name is Dr. Mario D'Alessandro. I'm the Global Head of Pharma Business, and it is my pleasure to introduce you to Dr. Peter Bauer. Professor Bauer is our Centogene's Chief Medical and Genomic Officer. He's an expert in rare diseases and has been working in this field for many years now. He has more than 250 publications, and he has been also instrumental in building our bio data bank. Professor Bauer is board certified in human genetics and is also a vice president of the German Society and Neurogenetics.
So Mario, thanks for preparing the stage, and welcome everybody also from my side. So I'm glad that you joined, and I'm happy to share with you the next 45 minutes on our agenda, which is understanding the clinic and genetics of Duchenne muscular dystrophy and Becker muscular dystrophy, both called the dystrophinopathies. And then see that this field is quite amazing because we have had a lot of emerging therapies in the last years and significant research insights how we can bring treatment to these patients. And kind of from there also what Centogene has done in the last 10, 15 years in accompanying these families and patients with molecular diagnostics. What have we seen in many, many countries around the world, and also what this cohort of patients and the insights might help us to also unlock for being faster in therapeutic development, but also in better understanding also the prospects and sometimes also the limitations of these approaches where differential therapies will be more and more important. So let's go to end of the first chapter, which is how we understand DMD and BMD. And there I would like to start with the notion that both diseases have a common genetic background, which means these disorders are caused by mutations in the very same gene, which is called the dystrophin gene, DMD, which codes the very same protein, also called dystrophin. And as expected for muscular disease, this protein is essential in developing a normal physiological muscle strength. It's located in the muscle cells, connecting the sarcolemma and helping to exert the force, the molecular force that is built up there. And dystrophin is one of the largest genes in the human genome, and thereby also one of the very large proteins, peptides, polypeptides we synthesize. So it has a crucial mechanical function linking the cytoskeleton and the extracellular matrix. And without that kind of a regular healthy muscle force cannot be produced. So huge means many, many exons, which is small coding fragments of the gene on the X chromosome. And this also means that the susceptibility for severe disease is mainly in the males. We hardly see sometimes females with special genetic conditions that also have severe disease, but on average, female manifestations are much milder. Since the gene is so large, we have a quite high rate of de novo mutations, which means we have an affected boy very often, and the mother is tested normal in the dystrophin gene genetically, which implies that this event, the mutation, occurred de novo. The usual mechanism of pathogenic variants is that the protein is truncated and then the stabilization of the cytoskeleton and the functional muscular elements is disarranged. I will show you that in a cartoon on the next slide. The majority of the variants we've seen genetically really hit the coding region of the gene, and we have also hotspots where kind of these mutations happen more commonly. They are kind of in the second part of the protein, especially in exons 45 to 53. The precise mechanism how this deficiency leads to degeneration of the muscle fibers remains still a little bit unclear, but we know that the cytoskeletal disruption and the sarcolemmal instability together with an impaired calcium homeostasis does play a crucial role. Now, although this is one gene, we have two kind of disease phenotype typical presentations, and the differences come especially by the severity of the muscular symptoms, by the age at onset, and also by the accelerated or more slow progression of disease. But before we look and review the clinical picture, I would like to illustrate and go through with you about the molecular basis of the disorder. On the left, you see kind of a pictogram of a muscle cell where kind of these greenish dystrophin molecules with a large glycolipid complex link the extracellular matrix with the inner compartments of the muscle cell, and especially attach actin, which is the motor neuron, the motor of the muscular contraction, to these skeletal scaffold. And as long as dystrophin is intact, we can exert proper muscle strength and muscle function. On the right side, you see if this protein is absent or truncated, of course, we lack kind of the connections of these actin molecules, and then can no longer have a coordinated calcium-triggered muscle force, but we have kind of a situation where even these molecules start to destroy the muscle cell. So in principle, we have a disassembly of the structure of the internal structure of the muscle cell that leads to the kind of functional deficit and later also to the fibrosis we often see in the long term of disease. Now, the key differences between Duchenne muscular dystrophy and Becker muscular dystrophy, as said, can be found in the age at onset, where DMD typically manifests in childhood at age 3 to 6, with early symptoms and delayed motor skills, while Becker muscular dystrophy is seen in the adolescence and early adulthood, and usually kind of the development milestones are still normal. Same differences we see in severity and progression, where DMD is having a rapid progression of muscle weakness, leading to a loss of ambulation in early teens, and a significant reduced life expectancies, which often does not exceed the 30s or 40s, while the Becker muscular dystrophy is much milder, slower progressive, and many of the affected individuals retain their ability to walk in their 30s and beyond, while life expectancy is also longer. Also the pattern of weakness is very much pronounced in the kind of strong muscles in the shoulder girdle or in the pelvic muscles, while in Becker we have typically calf hypertrophy, which shows kind of already the hypertrophy of the muscle to compensate for the loss of strength. When we look into the genetic mutations, we often see DMD is often caused by large deletions or duplications in the gene, which leads to almost complete absence of functional dystrophin in the muscle cells, and thereby kind of the maximum damage in the, the functional setup. While in Becker, we have very often smaller deletions, in-frame deletions, or point mutations that still keep some resulting function of dystrophin and so ameliorate the phenotype. What is striking and important is cardiomyopathy is a feature of both Duchenne muscular dystrophy and Becker muscular dystrophy. But while the involvement of dilated cardiomyopathy in most patients in the late teens and 20s aggravates, of course, the DMD clinical picture for Becker muscular dystrophy. This can often be even an early symptom that is misinterpreted and not put in context with the dystrophinopathy, while kind of the risk also of sudden cardiac death is, of course, elevated, and therefore some of these patients never get diagnosed with their kind of peripheral muscular problems, but with their cardiac problems in terms of cardiomyopathy. So that's kind of a red flag or something to know if you're dealing with adult onset phenotypes, especially cardiomyopathy in males, should also include an assessment whether Becker muscular dystrophy could be the underlying reason for the clinical symptoms. Now, genetically, I already mentioned this is an X chromosomal gene, and so the prevalence is roughly 1 in 5,000 in males. But as I already said, also in females, although they are believed to be oligosymptomatic or asymptomatic, roughly 20% can have mild to moderate muscular weakness, and also elevated CK levels. So you might have even an endophenotype with abnormal blood values that you can explain with dystrophinopathy. And as said, also the cardiac involvement can occur in maybe less than 10% of the carrier females. And so that's also a significant proportion and a morbidity that should be accounted for. The recessive inheritance is very typically that from an hemizygous male, there won't be affected males, but carrier females. And from a carrier female with maybe mild symptoms, like I explained here, we will have 50% of the males affected with clinical phenotype, and 50% of the male progeny will have the carriership and also occasionally those mild to moderate muscular symptoms. So if we kind of put it together, I think the engram should be that you usually have an early onset in childhood, presenting symptoms with gross motor delay, gait abnormalities, a so-called waddling gait, and difficulties to rise from the ground. It's called a goer's sign, so where kind of the boys use also their arms and hands to kind of pull up, and not so much legs and muscle strength in the legs to rise from the ground. Clumsiness with frequent falls, and then sometimes also a more global developmental delay, typically, of course, increased levels of serum creatine kinase, and untreated affected boys have a very poor prognosis and will have impairment of walking early with wheelchair dependencies in their teens and late teens. But of course, advances in clinical management and new therapies have changed kind of this prognosis significantly, and we will discuss that in the second part of the presentation. I have put together, just for illustration, some illustrative cases which are a little bit virtual, but typically you have kind of a boy with normal motor development in the first month, but then at year 2 or 3, they start to be delayed in rising from sitting or from the lying decision. And this kind of Gower sign that is illustrated here, where this boy uses kind of his arms to extend his legs, is very typical. And you can find also some YouTube videos to illustrate that. Then later, of course, the wasting of muscle cells results in this pseudohypertrophy. You see it here in the muscles of the legs, where kind of the calf enlargement is significant, although the other muscles are rather slim. And of course, tiptoe gait or running with friends will not work any longer when they are 7 years and above. And then, as I said, if you don't treat, there's a high risk that the boy gets wheelchair bound, will have then the secondary complications with scoliosis and also progressive impairment of the upper extremities functions. And then in later, there is also insidious deterioration of the diaphragma, and then also problems with ventilation and support needed during nights. And that's also the most severe kind of impairment of the prognosis, that of course the ventilation is impaired with this muscular dystrophy. In a typical case with Becker dystrophy, you will see that they develop normal until into the teens. And then maybe at age 15, 18, there's a little bit of clumsiness, more frequent falls, a decrease in physical fitness, maybe early exhaustion when being challenged on a hike, or discontinue sportive activities. And then only slightly kind of seeing an early signs of muscular atrophy. And then with increasing age, again, skeletal consequences of the muscular weakness. Later, as I mentioned, the dilated cardiomyopathy, and then also in the 40s or 50s, loss of ambulatory competence. So all in all, very severe phenotypes with a mainly muscular problem. Now, let's review a little bit what has been emerged in the last years in research and therapies that can help to change the fate in these affected children, mainly boys, as I said. And so it's all in all kind of 4 therapeutic principles that have been explored. I am giving you here also some references if you want to go deeper. But one is that with gene editing, researchers tried to correct DNA, wrong DNA information, which is still very experimental, but is followed because these approaches promise to be more durable correction than the current exon skipping therapies. Here, in this exon skipping, we have already kind of seen great gains in therapeutic efficiency, which means in this huge protein, you are much better at the clinical performance if you lose a little bit of that protein, let's say 2 or 3 exons, in a very controlled way, but not produce a nonsense protein with out-of-frame protein translation. So the general mechanism of action is that therapies try to revert an out-of-frame problem into an in-frame problem, and thereby reestablish at least a truncated but still functional protein. This goes with antisense oligos or other vehicles directly to the muscle, initiates significant dystrophy in protein production, and covers quite a relevant mutational spectrum. An example there at the moment is, for example, DYN251, which we will see also later in some more detail. A good mechanism, but still experimental, is to try to upregulate kind of the twin of dystrophin, which is called utrophin, which has similar functions in the muscle cells, and might thereby partially complement the loss of dystrophin. So if you can compensate with more utrophin, the muscle growth and also the muscle strength can be positively changed, and also the muscle wasting is reduced. As said, this is still a kind of experimental therapies, and also some investigational stem cell and muscle cell regeneration approaches have been studied, which then would include cell therapy and gene therapy or ex vivo therapy, which I will not go into much deeper because this is not yet kind of too much established, except for here an AAV-based therapy, where an AAV vector with a microdystrophin is used to supplement this construct, kind of a shortened but functional dystrophin protein to DMD boys. And as we can see with exon skipping and AAV gene therapy, we try to target early cases, severe cases, and see that kind of the levels of normal dystrophin still are far away from being kind of physiological, but after repeated infusion, we see a trend towards slower decline, and which is also important, of course, with exon skipping, well-tolerated therapy with not many severe adverse effects. See, the renal function needs to be monitored, and of course you have to monitor also the beneficial effects, but other in kind of gene therapy, virus AAV-based gene therapy, there the therapeutic effect can be larger, but also the risk of kind of severe adverse effects is also higher, especially in the liver, but also in the heart, and you need to also co-medicate with immunosuppression, which also has its kind of course, specialities and also risks. Now, this is the two, I think, at the moment established paradigmatic approaches for DMD. Either exon skipping, very often to be repeated, less efficient but more safe, and AAV, which has also had some drawbacks because some of the severe side effects were fatal in the past, and I will come to that also in another slide. Beyond, in the US, there's also, of course, supportive treatment with glucocorticoids, which have shown to stabilize muscle strength and are a standard of care and approved. Then you can see that we have different modalities for the exon skipping for different exons, also different drugs that make sense because you have to be specific for the exon intron junctions to establish this mechanism. And so this is typically also applied in young boys. And then, as said, the gene therapies, also studies with some good functional effects, but a higher risk of course, side effects. In Europe, the portfolio is not so completely filled, but we have as well the glucocorticoids, state of the art, and then we have an approved read-through that helps to overcome a stop codon that would cause the disease, and also with a conditional approval, an HDAC inhibitor with some beneficial effects. I think it's important enough to see also that the understanding sometimes of side effects is unfortunately surprising but relevant, and we had essentially with all of these AAV-based gene therapies, that's kind of a publication from 2023 that used these microdystrophin constructs. We have seen that they reported especially inflammatory side effects that were surprising, not predicted, and working that up, and details can be found in that paper as well. The models to explain is that either this new microdystrophin that was inserted is antigenic because it has a different size than the kind of the natural occurring, or that in those boys with absence of dystrophin, also the natural immunity or the senescence of the immune system toward that epitopes has not happened, and thereby then kind of putting bad dystrophin into the system, which you want to do, creates kind of an inflammatory trigger. And of course, it's always also possible that the AAV capsid might have some contribution in this severe adverse effect. So unfortunately, this has, of course, stalled the development there, and approaches need to be redefined and risk profiles need to be spelled out so that kind of the benefits and the risk are in the right balance going forward. Now, after this review of kind of the phenotypes and at the moment the therapeutic arena, I would like to also share some data from Centogene's DMD cohort, which is a quite substantial and impressive one, and just walk you through which type of data we can look at over the last 10, 15 years of our engagement in that disease. And what you can see is that we have done a lot of testing. Typical testing, and this is more technical, is done single gene because the suspicion of Duchenne muscular dystrophy is quite specific, and so the requests have often been, could that be a Duchenne muscular dystrophy? In those cases, we do a single gene, or did in the past, single gene analysis, and then very often also went for copy number analysis because that's the most common type of mutation, a deletion in that large gene. And as you can see, that very often in more than 1,300 cases brought a diagnosis with a typical known deletion or duplication in the gene. We have also added then in the second step Sanger sequencing, or vice versa, from Sanger sequencing into confirmatory MLPA. And you can see at least also direct sequencing brought almost 370 diagnoses with single nucleotide variants, mainly point mutations, stop mutations. And we have also the same that we have in a combined approach very often then validated the CNV by having single nucleotide variants checked and MLPA done. So that's the big picture. Of course, also in exome genome sequencing, this is covered, and we have a couple of hundred of diagnoses as expected, a larger proportion with CNVs and a smaller with single nucleotide variants. And we also have kind of sometimes special tests that we designed for screening that I will not go deeper here, but the majority usually in the diagnostic is you have to identify deletion or duplication in the dystrophin gene, and in 1/3 you go for the single nucleotide variants. What is interesting is where did we do that? So you know Centogene is operating globally, and we get samples from the Middle East, from Africa, and as you can see here, we have really a high number of DMD patients, especially from North Africa, Egypt, where we did also larger screening programs, but we have also a significant cohort in the Middle East and in Europe, and a smaller one in LATAM, mainly Mexico, but also a little bit in South America. Only a few cases in the US, but it's a diverse cohort, and therefore it's also interesting to share the next slides with you, where we show whether the phenotype and the clinical observations are different from those that you would expect. First, this is kind of the pileup of numbers identified over the years, and you can see it's almost every year that we diagnose something like 400 or 500. We had a peak with a larger screening program in 2019, but this stopped then in the pandemic, and now we have kind of a constant flow of new cases. The pileup here from 2016 to 17 is related also in having more dedicated screening programs, but also having kind of exome genome sequencing more routinely adopted, and thereby not missing these cases. And if you look on the right, what is the proportion of patients with an indicated age? You see the majority of the cases we diagnose when they are, let's say, 6 to 10 years old, which is also where we see the highest impact of the disease in the Duchenne phenotype. So this is mainly representative of the Duchenne cohort in our biodata bank. Then, of course, also interesting which type of symptoms are reported when we receive these samples. And you know we do the coding into HPO terms, which can then be jointly analyzed in these hierarchical ontological systems. And the most prominent clinical symptom is a lab parameter, which means if the pediatricians see an elevated creatine kinase, they go for also exclusion of dystrophinopathies. We also have even more specific mention, 800, almost 900 cases where specifically Gigower sign was noted. And then I think the electrophysiology with myopathic abnormalities is also something done quite often in these patients already before a diagnosis is established. And then you can see that that's the beauty of HPO terms. You would have also another term that is called abnormal circulating creatine kinase concentration. Of course, those 400, they can be integrated with the 2100. And when we do kind of cohort analysis, this is all brought together through the HPO ontology. So it's a great tool also to understand the differentiations, but also the lumping of phenotypes in very good detail. Now, if we check how secure can be a molecular diagnosis, we have almost 4,200 cases with a very probable diagnosis. And we have 159 with a possible diagnosis. A probable diagnosis is when we have really a connection of a pathogenic or likely pathogenic variant and the clinical picture, while the possible is when we would have a variant of uncertain significance still. That's usually then a rare missense variance where we have to be a little bit more conservative in the genotype-phenotype interpretation. And what is also kind of already in the data you've seen before, roughly 70% of the variants are copy number variants, pathogenic, likely pathogenic ones, and 1/3, but still in 1,500 individuals has a single nucleotide variant. So you have to do both. You can think of a kind of a sequential workflow where you do an MLPA, which is quite cheap in screening first, but then you have to add full gene sequencing. And so that's what we also would recommend, because kind of copy number and sequencing in our standard exome and genome backbone works very, very high quality. And so I think that is usually the best test you can choose, which also helps you if we don't come back with the diagnosis of Duchenne or Becker dystrophy. We still can check other muscular dystrophies and may establish a diagnosis in a patient if it's another molecular cause. So all in all, I think that's what I wanted to share with you, kind of the clinical picture, what is now developing in terms of therapy, which makes the diagnosis and knowing about how to establish a diagnosis even more important today. So to summarize, we have, I think, seen today that the dystrophinopathies with Duchenne muscular dystrophy and Becker muscular dystrophy are really an important field for establishing a diagnosis, because we have emergent therapies, and this real-world data that Centogene has collected also helps to understand where are the patients with which mutational patterns do we see in different countries. Are there, besides the large fraction of de novos, maybe also some founder mutations that should be worked on? And along with the research in therapies, I think one of the most important things is kind of try to fix the immunogenic problems with the microdystrophins in AAV-based therapies to open that also for the broader use, because at least arguments for convenience of applications are in favor of that therapy. And will reshape the landscape. And then kind of last but not least, I think it's not only that we have a huge understanding of how to classify variants and how to come up with a very precise diagnosis. We also collect kind of very often, right, that's what filter card from these patients, and with research consent also, this is a very nice cohort to start working on multiomics, understanding better also modifiers of disease progression, and maybe alternative also targets for therapies in the future in some scientific or company-to-company collaborations.
Okay. Okay.